well, which is obviously the other side of the scale than what we work with here at LSIN. So when I use we and I mostly mean physical therapists as a general, not necessarily like us at Physiotherapy Associates of Lansdowne. So when I'm saying those words, it's just PT in general. So what is a physical therapist? There are many different niches in physical therapy. Outpatient orthopedics, pediatrics, geriatrics, your inpatient rehabs and home health care, tons of different ways you can go and concentrate in with a physical therapy degree. All now require a doctoral education as a new graduate, and we're trying to advance the rest of the clinicians who are currently practicing towards a doctoral level or a specialty of some variety. We're encouraging that continuing education to get those specialist degrees and become more advanced in our clinical practice. We are movement specialists. What that means is basically we are the most qualified healthcare professional to diagnose movement dysfunctions. We look and address the underlying biomechanical issues that cause your pain and lead to dysfunction. And we utilize functional anatomy. And what that means is, yes, we're looking at your bones and your ligaments and your muscles and how they work and flow, but we're looking at them in a gross motor pattern. So how are you walking? How are you bending and lifting and moving? Squatting? How are you sitting and climbing the stairs? How are you reaching your arm up? We look at all of that as it relates back to your function, as well as the anatomical structures that are needed to perform those activities. And feel free to ask any questions as I go along, but there will be time at the end. Yes?
Are you going to dance?
Sure, at the end. I'll do pirouettes for you. As I present, I'll probably sit here and swing because
you have been dancing.
I've been told that when I present, that's what I do, is I just sort of dance around. All right, so macrobiology versus microbiology. So physicians are microbiologists. They utilize imaging, microscopes, blood tests. They're looking at chemical balances, the microscopic changes in the body, things that you need, again, that order of test in order to appropriately diagnose. They're ultimately looking at the pathology that may be causing your pain or your ailments and sickness, and etc. PTs are macrobiologists. Going back to that, we're using those whole body movement patterns. We're looking for your muscular imbalances. And ultimately, we're diagnosing the movement dysfunctions that cause pain. So a good example of this, just for comparative, we have a 75-year-old with back pain. Insidious onset, may have hurt themselves a couple of times when they were younger, when they played football, or that one time they bent over and tweaked themselves when they lifted a heavy box. But for the most part, just generally, I don't really know what I did this time, it's just hurting. A physician goes in, uses an x-ray or an MRI and diagnoses them with stenosis, basically a narrowing of the canals, and I have a picture of it for you. A PT, we're going to look at this, and we're going to look at the movement pattern and diagnose them with a spinal extension dysfunction. So, this is an MRI of spinal stenosis. What you're going to see here, this is a typical vertebral level. You've got a really nice full disc, a really nice foramina here, basically the hole in which the nerve exits your spinal column and goes out to your extremities. Really nice, good spacing, nothing happening, shouldn't necessarily be the source of pain. Then you look at this disc, see how tiny and flat it is? So he's got degenerative disc disease. This happens in everybody. It is normal as we age. Sorry. But that doesn't necessarily mean that it should cause pain. Then you look at this foramina and how tiny it is. That puts a lot of pressure, causes a lot of inflammation and angry nerves. So you get somebody who looks like this. When they stand up erect, they get pain in their back, they get pain that shoots down their leg. Then they have what we call shopping cart sign. They bend over a shopping cart and they push, they're like, I hate walking, but when I go to the grocery store, I feel great. And you're like, haha, I know exactly what's going on with you. They start to go into a flexion posture. When you're standing and you're up erect, your back naturally goes into what we call lordosis, aka extension. So this, but obviously not as significant. As soon as you give a shopping part to a person, they're all of a sudden leaning over. They come out of that, they put a lot less pressure. They open this space up and allow that nerve to breathe again. That's why they have pain, but not as much pain. Then they get into this lovely sitting posture, as all of you are nicely sitting, like this, right? But none of us sit with good postures anymore. So all of a sudden they've taken all of the weight off of their spine, they put it into a nice flexion posture, and they're really happy in that sitting. So why we call this a spinal extension dysfunction is because they can't extend. It hurts. There's too much inflammation, too much anchored nerves to be able to go into this posture. That does not mean that they are completely limited in that, but that we need to address that dysfunction and help them be able to achieve those postures without pain. So, microbiology, macrobiology. Same issue, but we're looking at it in two different ways. But, that being said, we love to take our x-rays and MRIs, right? Well, we did a bunch of studies to support that. Not necessarily do imaging show what the actual problem is. They took a cohort of individuals who had no back pain whatsoever and did an MRI on them to see what pathology was shown. 91% of them had disc degeneration. 56% of them had disc height loss, so that was that squish disc. 64% had a disc bulge, so that's where the disc slightly pushes out backwards. 32% had a disc protrusion, so that's slightly worse disc bulge, it pushes out even further, potentially even pinching towards the nerve at that point. And 38% had an annular tear, and these were people without back pain. No issues whatsoever. And they had all of these things that doctors look on imaging and go, that's your pain, that's what's causing it. Is it really? Or does your population just happen to degenerate over time? So, this is where, when we go back to physical therapy, we do our initial evaluation. Yes, please bring us your imaging. We like to know what's on it. But no, that doesn't tell us everything we need to know about your case. Going back to that stenotic patient, every stenotic patient is different. It doesn't matter if it's the same L5 stenosis from one patient to another. They all have different complaints, different issues, and are going to heal at different rates. So, then going on, another study looked at what was a better predictor of back pain and depression. This could be a whole other presentation now. Depression is a better and stronger predictor of back pain than MRI findings. We see this a lot. My older individuals come in, they've had back pain for years and years and years. They've just recently moved homes or had to move in with their children. There we go, that's the right one. They've moved in with their children, their life situation has changed, or they'll come in and be like, I don't know, I just started having back pain, and it happened about 6 months ago, and we're talking, and all of a sudden they're like, and my dog died 6 months ago. And you're like, got it. So you have back pain, but it's back pain, and we have to fix it. But we might be doing more psychosocial aspect of this care than we are truly working on other things. But because of this depression, they're not moving, they're not doing things they used to do and love, so now they've become deconditioned, they're not as strong, their core is not as strong. There's a lot of things we can address to help them with their back pain, but there's a huge psychosocial aspect that we, as PTs, go into with it. But anyway, so again, Jarway 2005 said pathology did not predict the presence of low back pain. All right, so what is outpatient physical therapy? So patients typically bring themselves into our clinic 1 to 3 times a week. Kind of depends on the diagnosis and what they need from us as far as care. Patients are not homebound. What that means is these patients have the ability to leave their home in terms of health status and safety. So home health has come in if they needed home health and worked with them, and they're now no longer homebound. They can get out into the community, come out to see an outpatient physical therapist, or they never had home health in the first place, and they're an active senior who all of a sudden was, like my grandfather, up on a ladder doing things, all of a sudden fell off and broke his ankle. Great job, grandfather. Great job. So, you're going to have your different types of seniors, but all of them ultimately are able to leave the home and come out to an outpatient facility. They don't need somebody to come to them. Therapeutic episodes will typically last somewhere between 1 to 3 months. Again, it depends on the person, how they progress, what the pathology is, etc. You can utilize insurance, though a lot of facilities also have self-pay rates if necessary. And of course, for our seniors, Medicare, I think every clinic I know, except for the ones that are specifically self-pay, take Medicare. Most patients will get a prescription from their doctor, but it's not necessarily needed, and I'll go into that further on a different slide as far as Virginia physical therapists are concerned. What happens when you first come to see us? Most patients are like, "Ooh, I have no idea what outpatient PT is. I've never had PT before." Your first visit with us is typically an evaluation. We talk with you, we find out what's your problem, whether it be balance or pain or just weakness in general. What are we working on? What your functional level is and baseline is right now, so that way we know where we're working on and what we want to work towards. And then it's a bunch of different objective measurements. We look at your walking, reaching, we do range of motion measurements, strength measurements. If it's a balance patient, we do some balance scores. And it's basically a lot of testing that first visit. And one of the things people seem to love to believe about us is that we're miracle workers. Thank you. We're not. I'm sorry. Yes, we'll make your pain better, but it's not going to be the first visit. We don't have magic fingers. I apologize. So with that being said, a lot of patients come in and they leave that first day hurting worse. And we're sorry, but we have to do a lot of tests that provoke your pain in order to figure out what makes your pain better. You know, where are your issues, so that way we can work on them and make it so they're not issues anymore. So a lot of people get really disenchanted with us that first visit if we don't have the time to go back in and make you feel better. Sometimes we do. Sometimes we can get into treatment and we help you leave clinic feeling a little bit better than you walked in, and that's always our goal, but sometimes we can't. And just letting your patients and your seniors that you work with know those things, because it helps them in the long term know that once we see them for a month, we'll be able to look back and say, yes, we're better. That being said, if for some reason they're not getting better, that's when we go back and go, all right, time to go back to your doctor. Because you're not getting better, and maybe we need to look into other plans of care. So, typical diagnoses we see in outpatient physical therapy. We have your post-op orthopedic surgeries, total knee replacements, rotator cuff tears, lumbar fusions, etc. You name it, we do it. We have general body aches and pains, so your chronic low back pain patient, your chronic neck, knee, shoulder, post-MBA, that kind of thing. Your sports and work injuries, so your athlete with an ACL tear, your sprained ankle from a work fall, etc. We have your balance, and this goes back to that senior care. We do decreased balance related to age-related decline, as well as fall prevention, so the person who comes in and goes, I'm really unconfident in my balance. I haven't fallen yet, but I'm afraid I'm going to. We work with them too. That is something that Medicare does pay for, is reducing and preventing balance and falls, because in long term it's actually cheaper to do that than it is to pay for that hip replacement after they broke their hip when they fell. General deconditioning after a long hospital stay, and other neurologic conditions. So you're looking at your MS, your stroke, that kind of thing. So our focus during your care, we're going to work on reducing your pain if pain is your problem, restoring your range of motion, making it a pain-free range of motion, increasing strength, facilitating balance, that's true balance for fall prevention, but also muscle balance within the body, because that's a lot of times where we see some of our functional movement pattern deficits, is that your muscles aren't working in synergy anymore. One's stronger than the other, and they're not doing what they're supposed to be doing. You know, when you're walking instead of nice and straight, I get the kid who kind of walks like this, or all sorts of things. We work on improving your function within the home and within the community. That is something as an outpatient physical therapist we can do. We can go forth and be like, you want to be able to go out to that grocery store and be able to walk the whole grocery store without pain? We can set that as a goal. It doesn't have to just be household ambulation. We can work on community ambulation, or Medicare won't pay for this, but working on maybe returning to golf if golfing is something you really like to do with your friends, and you're retired now and that's what you want to do with your time is golf. We can work on that. That goes back to that returning to recreational activities, and then ultimately reaching what your patient-specific goals are. If you come to me and you're like, I just want to be able to hold my grandchild again without my back hurting, I can do that. All right, so in Virginia, most insurances do not need a prescription to see a physical therapist. That means you don't have to go see your doctor to come and see me or any other direct access physical therapist, which all master's degree, have become direct access certified, can also see direct access patients. This includes Medicare. I just learned that the other day, doing research on this. Specifics, you can be seen for whatever issue you have without that prescription, unless you've seen your doctor 90 days prior to coming to see me for the same condition. So say you hurt your back, and you heard it back in September, it's now November, but you saw your doctor in September for it, I need a script from your doctor. But if you saw your doctor in March for it, I don't need a script because that's over 90 days ago. Most of the time I can call into your doctor's office and be like, hey, you saw so-and-so for back pain back in September, gonna have a script for PT, and most doctors will sign off on it pretty easily. Some do want their patients to come back in, especially if it's been a flare-up of their pain or something like that that's bringing them to PT. The patient then must name a doctor for the therapist to send the evaluation and plan of care to be signed. But that basically lets us treat for 30 days without unrestricted care, basically. At that point, 30 days, if you still need physical therapy, you must go back to your doctor just to say hello to continue therapy, but that's about it. So studies are being generated, and there have been some more preliminary studies that I'll talk about here in a second that look into insurance usage, overall changes in healthcare dollars spent, and time to recovery if this direct access is utilized by patients. This is a systematic review that looked at 8 different articles looking at this preliminary research between direct access referred patients and physician referred patients. Not only did patients get in to see the physical therapist earlier, they had a lower physical therapy visit utilization rate. They had a decreased need for outside medical visits. They had decreased imaging performed, so decreased use of x-rays, MRIs, CT scans, etc. Decreased medications, and an overall decreased rate in healthcare cost. There have been other studies that show that physicians primarily will overutilize imaging, overutilize medication prescription, and underutilize physical therapy services. And obviously physical therapists, we use our physical therapy services, but we are very rare to go back and go, nope, I really think you need an image for this, unless we've tried to fix it for several weeks with no help or no avail. We have a bunch of different ways we do testing to make sure that if you're coming to us with an ankle injury, that we go through Ottawa ankle rules or Ottawa this and Ottawa that, and these are all these different tests to look at fractures and whether or not they should be sent for imaging. Whereas a doctor's first inclination is, don't care about any rules, if you're coming to me with ankle pain, get an x-ray, where it might not necessarily be needed. But just looking at this, and these are all preliminary and they need more research done and more subject volume on it, but preliminary things are showing that coming and seeing a direct access physical therapist can help you out and the insurance world out in long term, basically. So, and honestly, we're helping out the doctors because they're overwhelmed as it is anyways, and if they can have an ankle sprain come in and see us and they have more time to deal with your patient who's very first showing signs of diabetes, they're much more apt to deal with that than we are. Whereas we're much more apt to deal with, yes.
So if someone comes in, for instance, on that ankle sprain and you do 30 days and they're doing really well, but then they start having pain again like 2 months later, can they go back to direct access, or does there need to be a specific period of time to be treated for the same condition?
At that point, so if they came in and they were 30 days out and they say continued for another month, they had to go see their doctor for that injury anyways, and they're coming back 2 months later, that's still not within that.
I mean, they never saw the doctor.
Oh, they never, so I saw them for a month and discharged them.
Right.
And then they came back.
2 months later, they started having issues again.
They can come back and see me. If they never saw their doctor for that care, then it's fine. And it's a new episode of care.
Okay, so does there need to be a specific time period where it's considered a new episode of care?
Yeah.
That's what I was asking. Does there need to be a certain amount of time between?
I don't remember the exact numbers on it, and I don't know that it's necessarily written out in the law.
Okay.
If there's an exact time frame. Yes, sir.
Yeah, is it the same as I'm on nursing home for years? Is it the same in the nursing home once they're discharged and they're not in a skilled unit and it's a 30-day period? Isn't it 30 days that they have to come back and start a new skilled building?
know whether or not, you know, that low insidious onset low back pain is an extension dysfunction, or is it their, you know, history of prostate cancer that is now metastasized to the spine, or is it truly a kidney condition because they really get that horrible back pain every time they need to urinate. You know, we're now at that point where we can do some of the screening for the doctor that, you know, we've looked at them and we've looked at their back pain, and we know that it's not really a musculoskeletal issue. It's more of a organ issue or something like that. I think that's a little bit more sinister. So with our doctoral education, that's where we have gone so we can do this direct access care and kind of be a more well-rounded, more integral part of the healthcare system. Yes.
With the Medicare and direct access, like with the adult children that we see, a lot of our clients are furniture walkers, and you see the fall coming. It's going to be there.
Yeah.
Is that enough for them to say, hey, my mom needs to be evaluated for balance issues?
Yeah. Sometimes the patient's not so willing, but like if you've got your family members that are concerned about it and want their mom evaluated for it, we can certainly evaluate. And maybe they're just furniture walker because it makes them happier, but more than likely there's a balance deficit there that the patient's hiding.
Right.
So.
Well, it might make it easier for direct access to get to you as opposed to get to the doctor, get a referral, then get them back out to PT. So they're going to be like, this is too much.
No, too much. Or sometimes even you get that step-by-step process where they go to the doctor and the doctor's like, yep, sure, cool, balance problem. You should see a neurologist for that balance problem.
Yeah, right.
And they have to see the neurologist, and the neurologist goes, no, you need physical therapy. And then they finally get to us, and it's been a whole month of this whole nonsense. And at that point, they're just really annoyed with us, and we tell them they're supposed to be in here twice a week. They get real cranky. So, but you know, that's where, you know, and you have to do that patient education piece that's, yes, you have to be here twice a week, because unless you're being compliant with your exercises at home, I can't help you.
Right.
You know, and that's a big piece of outpatient therapy. We're giving our patients this ownership over their own care. Whether or not the patients actually take on that ownership is up to them. But I always give the patients on the first visit at least one exercise to do at home, so that way they can start to take ownership. I want, and this is probably bad for my longevity of my job, but I want my patients to be able to self-manage beyond seeing me. So when I'm discharging, they are able to go, ooh, I'm starting to hurt again. But if I do those exercises Megan taught me, maybe I can make it go away. And that way they don't necessarily have to come back and see me, or maybe they come back and see me for a very short period of episodic care, as opposed to seeing me for that 2 or 3 months, like they did originally. But that's a big piece of what we do as outpatient therapists. There's exercises you should do and should take care of yourself, and postures you should maintain. And a lot of our patients, some buy into it, and others are just like, did you do your exercises? And they're like, nope, I didn't have time. I was like, so when you were sitting on the couch watching that television show you love to watch, you didn't have time? And they like blink at you a little. You had time. You had time. So, all right. Looking at outpatient versus other types of rehabilitation. Nursing and inpatient rehabilitation focus on improving safety to return home, for the most part, as a physical therapist around. Home health rehabilitation focuses on improving safety within the home, and these patients are your homebound patients, the ones that don't have the safety enough to leave their home situation or the health level to leave their home situation. And then outpatient therapy, we're focusing on restoring your maximal function. We're working to make your patient be the best they can be at their home, in their community, at their job, etc. And I love, this is like my favorite cartoon ever. It says, I think my work here is done. It's a guy standing, handstand on a wheelchair, balancing a ball and a cup. So, you know, patients think this is what we want of them, but really we just want them to be happy with their self. You know, and that's when I've done well. I had a patient the other day, hadn't seen her in a few weeks. She'd been traveling. We've been working since June on her shoulder issue. She came in, I reevaluated her to see what improvements she made, or if she made any regressions over not seeing me for several weeks. You know, where were we? She raises her arm up, it goes all the way up, goes all the way up to the side. We've been working to get her arm up her back for months at this point. It goes all the way up her back. You know, we look at each other, I test her strength, and it was just like this moment of, you've reached your best. Like, and she knew it, and she was so happy that, you know, we had gone from this point where she could barely raise her arm to full function, you know, deficits here and there, but nothing that she wasn't happy with. You know, it was something that she was like, I have come so far, and I'm so happy with what I've done. And yes, I'm there to lead you down the path and help you, but it's all about what you do and what you do at home, and again, putting that ownership back towards you as a patient and your seniors as patients. They need to take on their own care and their own health, and a lot of them get disenchanted with that. And so a lot of times I work just to restore, again, back to that psychosocial piece, I work to restore their enchantment and their own health and their own happiness of living and that quality of life piece. So, I think that's it. Is there any other questions?
And I was wondering about the X-rays and MRIs and CT scans. You know, obviously it's great any way we can reduce costs of healthcare and not have to do those kinds of testing, but just as devil's advocate, would it not be safer to have those each time and or also save money? Because if it doesn't work a month or two and then you go back and do it anyway, you know, I'm just thinking, like, would it not be better to just routinely get some kind of scan first so you can rule out certain things or make sure you're on the right path? Yeah.
So there have been things that look into that, but there is this idea of like the radiation that you get in your body when you're doing those images, and the overutilization of them can potentially lead to cancer. They haven't necessarily found a causation, but there's the idea that that's a possibility. And when you look at our, you know, these studies that look and show all of these issues that are in non-symptomatic patients, you know, when you image a person, are you really seeing what their true pain is? Or are you just seeing things that exist in everybody? And so then what was the point of doing an image just to take a picture to show you that they're like everybody else? And that might not be the true cause of their pain. Now, in an instance where, you know, that person, say you took a picture of their back and they have all these issues and we do therapy and things aren't getting better, and you then have to go take a second image, you know, say a more advanced image to try and find something else when you could have negated the x-ray in the beginning because they showed up like a stenotic patient, and then when they didn't improve with typical stenotic treatments, you know, flexion-based treatments, trying to open up and gap that space and get that nerve to calm down before then reversing that and getting them to gain extension range once their nerve is happier, for lack of a better word, you know, then you're looking at that x-ray first and then an MRI later, when you could have gone, well, we did stenosis-based treatment, it didn't work for a month, and now we're doing an MRI, so you just eliminated one image. And that MRI then shows that the stenotic changes, the osteophytes in that area are so pronounced that even PT can't help it, and then they do need that surgery. In which case, every patient that goes in for a surgery does get an image. Doctors love to know what they're getting into before they get into it. Which in their case, yeah, makes a whole lot of sense, because they have to know where to cut and where to go. But again, it goes back to that whole, we're hoping that's where the source of pain is. Because I've had patients who never got PT, had imaging done, imaging was like, oh my God, it's so severe and awful, and et cetera, and they had this huge lumbar fusion surgery, and they come out of it, and they're in the same pain. They're like, why did I go through all of that surgery? What did it do for me? And the question is, I don't know. And then I go through, yes?
I agree with all of that, with what she's saying and what you're saying, because I had something called a tree fragment.
Yeah.
And so that broke off on the physical therapy, and I came out of there going, that's the worst. And that indeed is a situation where the imaging picked up the tree fragment.
Yeah.
And the physician at that point said, get it out of there now because it's doing nerve damage.
Yeah.
On the other hand, then I've had other stuff where I think, you know, PT alone saved my life and got me back to feeling better.
Yeah.
So that's what I'm saying, I agree with.
Yeah, and so if you have that case, or you have a patient in and you're trying to get them better, and like every session they leave you and they leave you worse, hopefully, if you're a good enough physical therapist, you'll realize that really quickly, and you'll be like, you know what, this just doesn't seem right. And I always have that feeling in the pit of my stomach, like, ooh, I just don't know. And like that's that's when I'm like, okay, like let's talk about maybe getting out and going to see your provider again, and maybe even going, you know, a little step further and going to see the orthopedist this time because you came from your, you know, your family prac or whatever. So I do work towards, you know, and not every physical therapist is going to be the brightest of the bunch and be able to recognize that immediately, but, you know. This is true. What do they call the physician that graduates with lowest rank in class? Doctor. Anyways, same with physical therapists. So we can't all. Any other questions?
Well, I guess that goes back to the point of this direct access is only available if you are a doctor. So
Yeah.
you're
In essence,
probably
you
going to
should have that
the
training.
skill set
Yeah.
to figure that out.
You passed your boards. You should, in essence, know the information and be able to.
Are there any stats on doctors sending patients to surgery versus starting time in physical therapy first?
Some insurances put stops on it. So some insurances will not let a doctor take an image or go do a surgery without the patient first trying 6 weeks of physical therapy. But as far as like laws that stop doctors from that, no. But insurances, I've run across, I've had that patient, sometimes those are the worst patients though. You get that patient in who's like, I just need to do this for 6 weeks so I can get my x-ray. Like, I just have to do this, I don't have to get better, I just have to do it. And then I get my x-ray and I'm like, well, what happens if I make you better and you don't need your x-ray? I still want my x-ray. So you're gonna have those patients. And of course that's a personality thing with the patient. But I'll have insurance companies that do that. And some patients get better and they're like, oh, never mind, I don't need that x-ray anymore because I feel so great. Like, why do I need an x-ray? What's it gonna tell me that, like, I don't need to know? And then it sits in their back, you know, you show them that they have humongous degeneration in their knee and they're like, oh my God, I'm gonna need a knee replacement. I'm like, but do you feel really good now? Yes. I'm like, then keep doing your exercises. You'll probably feel good for a lot longer. Anyways, so.
But it's ownership too. I mean, like in my situation, I recognized that I was feeling worse.
Yeah, and I mean, you need a patient who's vocal with you
Yeah.
and will let you know, hey, what we're doing is not working. I have patients who also don't talk to me. They'll leave and they'll come back and they're like, I just hurt so bad after last session. I hurt so bad when we did things. And I was like, every time I tell you to tell me if it hurts, did you tell me that it hurt? No, I just did it anyways.
What's the difference between true pain and soreness from exercise?
Well, and there is, and so sometimes I have to work with a patient to get them to that point. And I was like, well, was it your pain or did your muscles ache right here? Well, I guess it was my muscles. I'm like, you're sore. You're supposed to be sore. But if they're coming here like, no, it was this pain right here, and it was worse, obviously then I need to relook at what we're doing, and maybe they're not doing an exercise appropriately, or they were trying to do it at home and we're doing it wrong at home. I've had that a lot. I tried to do that exercise at home, and I'm like, did I tell you to do that exercise at home? No, because you're not ready yet. But patients love to try and help themselves. It's my job to make sure they help themselves appropriately.
And on your side too, it's reversed with the doctors. A lot of times there's chronic pain or there's something they can't put their finger on, they automatically send it to PT.
Yep, they do.
I mean, they do it for seniors, they do it for peds, they did it to my son. She told me he has Erb's palsy, go to PT and OT. Physical therapist said you need to take your son to have an MRI, he's had a stroke. Lo and behold, went to UVA, he's had a stroke.
Yeah.
The doctor dismissed it.
Yeah, they're like, oh, Erb's palsy. But Erb's palsy you should know immediately at birth if they have Erb's palsy.
Right.
Like, that shouldn't just be, oh, 3 months later, or I don't know how old your son was, but like that, all of a sudden their arm is like not working anymore.
Well, you're like a catch-all for them. If I can't
They-
figure out what it is,
yeah.
there's pain or there's some kind of mobility issue, just go to PT.
Yeah.
You're not my problem anymore, I'll see you in 30 days when they tell me what's wrong.
Yeah, exactly.
You know?
So I get that a lot. Your chronic pain patient, just general chronic pain, so your fibromyalgia, etc., where the doctor's like, I give up, I don't know what to do anymore, go see the physical therapist, and I'm like,
Thank you.
hey, they've got 1,000 diagnoses, and you're like, I don't really know what's wrong with you either, but okay, let's try some exercise. So, and of course, they're looking at you like you're, again, that miracle worker. Sorry guys, I'm not a miracle worker. You have to work in order for my miracles to work. So, but, any other questions?